So it's 2:02, Dr. Boyce, so you can begin if you wish.
Am I recording or are you? You're recording, yes. Okay. Good afternoon, everyone, and welcome to this is our 49th Mrftt HIV STI Echo. We're almost at the big 5-0. Thank you, everyone, for coming. Thanks for all your support. I am Dr. Gregory Boyce. I shall be your facilitator this afternoon. Just want to shout out Conrad, who is our co-host with the Mrftt, and Dr. Edwards, who is our director, who is our subject matter expert and one of the members of our hub team. I hope everyone is being safe. I hope everyone is getting their vaccinations. I hope everyone is pushing a good message of getting COVID behind us at long last. It has been far too long. I hope we can get out of this as quickly as possible and with as little more suffering and devastation as possible. So we're going to jump right into the didactic for this afternoon. And we're going to talk about some of the updated WHO recommendations for systematic screening for TB disease, meaning for active TB, and it's slightly different than what we're accustomed thinking about when we talk about TB screening, right? And we'll see some of those differences once the presentation gets underway. Let's confirm, and can everyone see the screen properly? Yes, all right, we're good to go. So again, we're going to talk about 2021 updated WHO recommendations for systematic screening for TB disease and see the differences. So, just a quick note that this ECHO program was done in collaboration with ITech and the University of New Mexico School of Medicine, and we thank them for their support and all their advice in building this program. And so I have no conflicts, unfortunately, in relation to this presentation. So in terms of what we're hoping to cover today, we'll talk first about the global impact of TB, just generally. Let's just go over it, including persons living with HIV. We're going to understand the impact of misdiagnosis of TB disease on persons living with HIV, as well as from a public health standpoint. We're going to discuss the 2021 updated WHO guidelines for the systematic screening for TB disease in some detail. And we hope at the end to understand how these three screening guidelines can be adapted for Trinidad and Tobago to effect early diagnosis of TB disease. So what's the global picture for TB? So there are about 30 high-burden TB countries, and they account for 86% of all new cases of TB all around the world. And in that, 8 countries that are accounting for 2/3 of the global total. If you notice on the map, India accounts for 26%, just over a quarter of the global total. It's not the country with the densest TB population. I mean, you can see some areas, sub-Saharan Africa tend to have, and as well as Central and East Asia have higher density. But essentially, India, because the size of the population, contributes the largest number, right? And then followed by China and the Philippines. And in terms of the impact of TB among persons with HIV, it's about 8.2% of all new cases of TB in 2019 were among persons living with HIV. And again, in 2019, roughly 10 million people fell ill with TB. And of those 10 million, there were 1.2 million deaths among HIV-negative persons, and over 200,000 deaths among persons living with HIV from TB. TB remains the largest single cause of death among persons with HIV, accounting from somewhere between 30 to 33% of all deaths attributable to HIV. And chart in the graph sort of shows a good thing and a bad thing. The good thing is that TB death rates are declining and have been for the last 20 odd years, thankfully. The concern is that it's not declining fast enough to get to the milestones for the NTB strategy or the sustainable development goals that are due in 2030. The first milestone was a 35% decline in TB deaths from 2015 to 2020. It went up by just about 14%. So we're still not quite there yet. And so part of the reason why we're not quite there is that we still continue to miss cases of TB. We still continue to identify cases of TB late, and those facts drive morbidity and mortality among persons with HIV and tuberculosis, as well as generally all over the world. And this is where systematic screening becomes important. So first thing, what is it? It's a systematic identification of people with suspected active TB as contrasted to screening for persons we think might have latent TB. So it's a different mechanism, it's a totally different mechanism, right? In a predetermined target group, important, using test examinations or other procedures that can be applied rapidly. And it's sometimes used synonymously what we call active screening, right? And I know we have some, not active screening, so active surveillance. I know we have some of the QPCC staff who would be very well acquainted with the idea of surveillance for things like syphilis and gonorrhea and those sorts of things, right? So as I said, it must be distinguished from the screening for TB, for latent TB infection. What we're looking for is active TB disease. And in 2019, of the 10 million global persons all over the world who were estimated to have fell ill with tuberculosis, almost 1/3 of those, 2.9 million, were either not diagnosed at all or were not reported in WHO. And late, and you can understand this, if either late or undiagnosed TB, especially in persons living with HIV or their household contacts, is a major driver for morbidity, mortality, as well as spread through the community, because we all know that TB is something that is contagious, and it can have a serious detrimental effect on entire households and entire neighborhoods. And we also have to think about, and we'll come to this in some later down, in some populations, for example, where living in cramped living quarters, prisoners, people who are vulnerable, TB will have a serious impact on their health. So the first systematic screening guidelines were promulgated in 2013. Right? This is the update that was released on World TB Day, which is 24th of March, 2021, and was broken up into two parts: the consolidated guidelines on tuberculosis, and where it was essentially the who to screen, and the operational handbook, how to do it, right? So it was broken up into sort of two different parts. So it's a really interesting read, actually. So in terms of the modifications to guidelines, so the screening guidelines strongly recommend systematic screening for all persons living with HIV. Household or close contacts of persons with TB disease. There was a bit of a change from the old guidelines to newer guidelines, whereby the two populations listed in red were, I think, conditionally recommended. But now it went from a conditional recommendation to a strong recommendation when data came in respect to the potential impact of TB in those populations. So household close contacts of persons living with TB disease, prisoners, and current or former workers in workplaces with silica exposure, which is essentially migrants. So we're going to be focusing on persons with HIV, but the reason why I wanted to list all those things is for a couple of reasons. With respect to prisoners, especially given that Mrftt has a prison outreach, one of the things we need to consider, especially given these new guidelines, is do we need to change how we screen our prisoners for TB? Because I work in Cora, let me see, a couple, like last month or month before, there were 6 or 7 prisoners in Cora, all of whom had sputum positive TB. They seemed to be in the middle of an outbreak. So do we need to be specifically mindful of, are we screening our TB, our HIV cases in prison, even during COVID, right? For TB disease, right? And the other point I wanted to make with respect to the silica exposure, there are all these legal mines popping up all over the place in Trinidad and Tobago. I'm quite sure they don't have proper protective equipment. It may be something on the horizon you need to pay attention to. And in terms of the screening guidelines, is conditional recommendation, and again, the highlighted line in red was new to these guidelines. So in any population where the estimated TB prevalence is greater than 0.5%, it used to be 1%, that will lower the threshold at which screening should begin. And any person seeking healthcare who is already in care where the TB prevalence is greater than 100 in 100,000 population, any person with an untreated fibrotic lesion on chest X-ray, or subpopulations with structural risk factors for TB. I put that in blue, but it didn't show up too well. But just to highlight the fact that, again, one of the things that we hope to be doing is migrant outreach. Migrants and displaced persons, homeless, urban poor, and several other subgroups where they have increased vulnerability for tuberculosis. We need to be very aggressive, very purposeful as to how we screen those populations for tuberculosis, because otherwise what's going to happen, and has been happening, again, just in my own experience, that persons I see on the ward who are our patients, who've been in care for some time, when you go back into, and they're diagnosed with TB, and they're in CORA, when you sort of go back into their file, we never did a symptom screen, we never did a chest X-ray, we never did, ask those symptoms, do you have fever, cough, night sweats, weight loss? We never went into that aggressive screening, but with far too many of them. So I think this is something that we need to learn from as well, and need to implement more aggressively. So the first document that I showed you, the how to. So how to screen persons with HIV if we're doing systematic screening for TB disease. So the WHO recommends 4 different screening modalities. The first is the well-known 4-symptom screen, fever, night sweats, weight loss, productive cough. What is new is C-reactive protein, which is actually, we'll get into a little bit more detail, which is a blood test that actually detects the presence of inflammation. It's not specific to TB, but in the context of a person with HIV, and in certain circumstances, it can be helpful with respect to use as a screening tool. Chest X-ray, which we all well know. The trick is that the sensitivity depends on the population. And one of the things that the WHO started recommending now is the use of computer-aided detection software for interpreting digitally captured chest X-rays. The sensitivity to detection of TB was found in several studies to be equivalent to human learning. Right? So, and there are now quite a lot of potential resources. Thus far, it doesn't seem to any of them are free, but at least for use to interpret those digitally captured chest X-rays, which can sometimes be helpful where, for example, you need a chest evaluation of chest X-ray in certain populations where either the reports will take a long time, or they just don't have access to specialist radiologists. That would be a potential option, but again, cost and availability is going to drive that in. And molecular WHO recommended rapid diagnostic tests in Trinidad and Tobago, what we use is GeneXpert. We tend to use GeneXpert in diagnosing suspected TB. What WHO is starting to suggest that in some settings, and we'll come to that, it can be used as a screening tool, right? To screen as a screen and treat tool in the diagnosis of active TB disease. And the table to the left, which is again that came from the handbook, is comparing the sensitivity and specificity of the various different modalities there, whether it's a prolonged cough, which is just about 42% sensitive, but almost 95% specific for tuberculosis, versus, let's say, a chest radiograph, which is any abnormality chest radiograph, which is very specific because it's sort of a broad brush, but sort of very sensitive, but not as specific. So we'll go through what the reasons for that would be. So the well-known 4-symptom screen that has been recommended for the last decade, all persons with HIV should be asked about the presence of these symptoms at every clinical encounter. The presence of cough of any duration, fever of any duration, or night sweats lasting 3 or more weeks in the preceding month. This is based on a 2010 study in New England Journal of Medicine, was more than 93% sensitive, but only 36% specific for tuberculosis. And you can sort of understand why, if the population you're studying is an immunocompromised population, because fever night sweats might be tuberculosis, it might be bacterial pneumonia, it might be histoplasmosis, it might be something else, depending on where that study was done. So even though it would be sensitive to TB, pick up TB is there, it may also be other things that reduce the sensitivity, the specificity of the symptom screen in terms of diagnosing, not diagnosing, in terms of detecting TB accurately. So any one symptom had a 1 in 5 positive predictive value. The absence of any symptoms, however, had a negative predictive value of 97%, so which is fairly comforting. But performance may vary by subgroup. I will come to those subgroups now. So this was the results of, and you'll see this sort of table replicated as we go through different screening modalities. They would perform meta-analyses in terms of TB screening for the different screening tools in all persons with HIV, in patients, which is expected to be some of the sickest patients, outpatients on ART, outpatients not on ART, person with CD4 cells less than 200, so immunocompromised, and therefore you would assume clinically unwell, and as well as pregnant women living with HIV. And you see that the 4 symptom screen in terms of, I'll just highlight one line, the specificity was just about 11% in an inpatient setting, because you can imagine someone who is in hospital, living with HIV, who maybe they're because of advanced disease, and if you ask them if they have a fever, they may very well have, because they have some other opportunistic infection or a cough that might be PCP. These days might be COVID, right? So, and again, in the population that tend to be less clinically well, like CD4 count less than 200, it is less specific. But in certain populations, like for example, all patients on ART, which would be most of the patients we would see in our clinics, the specificity is high as 70%, but the sensitivity suffers. Right? It's down to about, it would miss about half of the persons with tuberculosis. We move now to C-reactive protein. So, as I said, it was a general marker of inflammation. It's what's called an acute phase reactant. Essentially, any inflammatory process that is occurring, whether it's bacterial infection, viral infection, fungal infection, lupus, autoimmune disease, whatever, your C-reactive protein levels will go. So tuberculosis is no exception. What they found, however, in the context of tuberculosis, especially in areas where tuberculosis is highly prevalent, and this is one of the issues that is going to animate and drive how we adapt these recommendations to our setting, the sensitivity was better than the symptom screen, but it was still relatively low in certain subgroups. Again, in patients is just 12%. Person with CD4 count less than 200, 40%. All patients in ART, high sensitivity, again, 80%, but specificity, but low sensitivity, just about 40%. So it is a balance that we have to strike in terms of what screening tool best suits which population that we're seeing. And as I said, the performance of CRP as a screening tool will depend on the background prevalence of tuberculosis. Chest X-ray, it's recommended for use in parallel with the 4 symptoms. We'll come to some of those algorithms later. It has the highest specificity for tuberculosis screening among outpatient PLHMVs compared to the other tools to see. It says outpatient, right? I think that's actually supposed to be high sensitivity. It's supposed to 95%, but the specificity is very low in patients who are immunocompromised, as before. I mean, 7%. Computer-aided detection is really recommended by the WHO as an adjunct to this to chest X-ray screening, again to reduce some of the manpower requirements that might hamper some resource-limited settings in this context. And in terms of some of the molecular, WHO recommended rapid diagnostic tests. So essentially, we're talking about GeneXpert. It is the most widely tested platform and is most widely available, especially in this part of the world. The sensitivity is excellent, north of 90-95% in all patient groups. And it's recommended as a screening tool in inpatient populations where TB prevalence is over 10%. And one of the strong recommendations by WHO is that in, for example, an inpatient setting, we're looking to screen someone for active TB disease. They have a strong recommendation, just do the GeneXpert. And if it's positive, treat, because the sensitivity is high in that population. What might hamper rollout, however, is cost, because it is compared to some of the other technologies, are fairly expensive. I mean, doing a symptom screen is free CRP. They have point-of-care machines that have a relatively low cost per test. So you would not want to cannibalize your ability to diagnose TB by doing widespread screening, because essentially you consume all the kits and testing thousands and thousands of patients and not be able to diagnose TB when the kits are exhausted. So I just wanted to briefly touch on how we can adopt sort of an algorithmic approach to combining different screening tools among persons with HIV. So this is just 3 of the algorithms that were represented in the WHO document. One would be what is called a sequential negative screening algorithm. So essentially, based on the symptom screen and a CRP. So we start with symptom screen. If the symptom screen is positive, and again, we also have, I didn't mention before, the availability of what is called lateral flow LAM, which is a lipoarabinoman assay, which has the highest sensitivity in persons with CD4 counts less than 100. Right? So if they have a positive symptom screen, you go straight to a diagnostic evaluation, whether it's a molecular test or clinical evaluation. If they have a negative symptom screen, well, then again, it's a sequential algorithm. Then you do CRP. If that's positive, then you proceed to further diagnostic evaluation. If it's negative, then you evaluate whether the person is a candidate for TB preventive therapy. The next one is a parallel screening algorithm for using the symptom screen and chest X-ray instead of CRP. But what's done, you do both the chest X-ray as well as the symptom screen on the same person on the same day. And depending on the bubble, if either is positive, you proceed a clinical evaluation. If both are negative, then you again evaluate whether the person is a candidate for TB preventive therapy. And the final one would be sequential algorithm using the symptom screen and a chest X-ray, as opposed to the parallel screen where you're doing both at the same time and deciding on how you manage a patient based on those results. So with the sequential algorithm, now you would do the symptom screen first. If they have a symptom screen, then you proceed to chest X-ray. And if the chest X-ray is positive, then you proceed to clinical evaluation. The potential drawback of this is it may be slightly more time consuming. There's a potential for a person dropping out of care. The other, the potential positive to this is that it's less resource intensive, in that you only do a chest X-ray if the person has a symptoms, has a positive symptom screen. Right? So that you're not doing that evaluation on every single person you screen. The drawback of that is that, however, is that remember symptom screening in certain populations is not very sensitive. So if you're basing your algorithm on that, you're going to miss everybody who is symptom free will miss. Right? So I sort of color coded the different algorithms because just to demonstrate how the performance of the algorithm changes based entirely on the TB prevalence in the population of this study. I wanted to emphasize population on this study, not necessarily general population, because we have to think about each subgroup as a separate entity when we think about how well these algorithms are going to work. And if we, for example, the incidence rate in Trinidad is about 18 per 100,000 generally, but that varies by geography. It varies by subgroup. It varies by other risk factors. So that would have an impact on what these numbers look like. But for example, if you check the blue line, which is the first algorithm we spoke about, which was the CRP, and let's run back quickly, CRP and symptom screen. In terms of the positive predictive value in a country where TB prevalence is 5%, it's 70%. But if the prevalence drops to 1%, that positive predictive value drops to 16%. Right? And you go from detecting 72% of prevalent cases down to 15% of prevalent cases. So we have to be mindful of these sorts of factors when we think about how we apply and adapt the different screening tools to our population. The same sort of thing when it comes to the second algorithm, which was the parallel chest X-ray and symptom screen evaluation. In a higher prevalence setting, you're detecting 71% of cases, and the positivity value is 70%. In a lower prevalence setting, the positive predictive value drops to 20%. Similarly, with the sequential algorithm, from 81 to 35. So what this tells us is that we need to ensure that we have good data with respect to what the TB prevalence rates are in different groups in the study, and not just lump everyone together and assume that one screening algorithm will work for all different populations. So in summary, TB remains a major source of morbidity and mortality among persons living with HIV. Over a quarter of all estimated TB disease went undiagnosed or unreported in 2019. Implementation of systematic screening for TB disease in groups most at risk is key to driving down rates of new and relapsed TB. The WHO recommends use of 4 different screening tools, either in parallel or serial algorithms, in order to detect TB disease and effectively linkage to care. And the algorithm best suited for our setting will be determined by local access to resources and TB prevalence rates in general, as well as in special groups. And thank you, that's it for the presentation. If there are any questions, please feel free to unmute and ask. Going on, please feel free to type in chat box.
I'm just wondering, at this time when every healthcare system is concentrating on COVID-19, when our patients present to most of the outpatients, they have cough, fever, and I think what people run to is screening for COVID-19, and I don't think they do anything else. Two, from what you've said, it seemed it would be very important to screen the general the displaced people, especially those we have at CSSDP, on time, so that we could make the diagnosis of TB early, so that they can be started on treatment, rather than waiting until they become very sick before they are screened and started on any medications. Something, I mean, which might not be related is, do we have much of multi-drug resistant TB in Trinidad and Tobago?
Right, so thankfully not. I don't have the exact numbers because that would be most of the national TB program in terms of what the numbers are. But it's single digits from what I understand. Out of, let's say, 200, it's usually between like 220 and 250 cases a year. The multi-drug resistant TB tends to be either single digits or, I mean, I haven't seen teens in a while, because it's one of the things that I think one of the previous heads of the TB treatment hospital was very phobic about. Because this is Dr. Senanan, so a lot of the success in TB program was sort of based on the information she built. And she was very careful about ensuring that we don't have a much multi-drug resistant TB. Now, especially with, I would say, slightly more aggressive implementation of the TB Act, yes, which allows, for example, law enforcement to return patients under force of law to TB treatment if they default. It's happening less and less, because there's a legal imperative encoded in law that you must complete TB treatment. If you walk out of hospital, you can be jailed.